Mic's on? Not yet? Thank you. Can I call everyone back into the room, please? There will be more time for networking and chatting at the end of the conference, so this is not the end of the fun, believe me. So we have two different events now. The first one is the last formal talk of the day. And this is a particularly interesting talk because what you're going to hear in the next 15 minutes is actually what the research is that you, as a group, have sponsored. So you all know that there are fundraising events, and CNETS raises a lot of money, and some of that money goes to research, basic research. Every year there's a competition, and there's a grant review by many of the eminent people you've heard speaking today. And this year's research presentation is very near and dear to my heart because it's actually going to be done by a pathologist. And so I want to call Dr. Philippe Joubert to the podium to give us a little update on some of the research that he's been doing.
So thank you very much, Dr. Rassa. Thank you very much. Good afternoon. I apologize in advance for some hesitation I may have with my presentation. You know, I've been back in Quebec City for a few years now, don't get to speak in English much anymore. So I might have to use a new language that I created while I was doing my fellowship that Dr. Travis used to call the Franglish. So I'd like to start first by to say thank to the organizing committee for the invitation. It's a real great honor for me to be here today, and it's a great pleasure and you know, today it has been a very inspiring day for me as I've been hearing stories from patients. I've seen great work being done by my colleagues across Canada, in different areas of Canada, different centers. You know, I'm a pathologist, but I'm also a scientist, which means that I'm supposed to be working 50-50%, but in fact I'm working 75 and 75%. And sometimes I'm working on Saturday night trying to wrapping up a grant instead of watching the Montreal Canadiens beating up the Toronto Maple Leaf. That should be the other way around, right? And I wonder, why am I doing this? And you know what? I think somehow it's because I feel that I want to make a difference. I want to make a difference for the patient. And having this opportunity today to meet the patient, to hear the stories, it's a very powerful source of motivation for me that tells me, Philippe, keep doing what you're doing in research and keep working hard. So thank you for having me here, but thank you for being here today. So everything is relative in life, right? So when I woke up this morning, there was 6 inches of snow on my car. No kidding. And they had to actually de-ice the airplane because we could take off. And then we land in Toronto and there's no snow and the weather is awesome. And I say, wow, these people, they're so lucky. And then I hear someone from New Orleans that says, this is a very cold place. And everything is relative. And this is my colleague, Christian Couture, who is actually a thoracic pathologist at my institution. And this is what he had to shovel a path to get to his shed. And actually, believe it or not, this is what it looks like in my backyard again today. So everything is related. I like snow though, but. So those are my disclosure, anything related to what I'm about to present in the coming minutes. So this is the most important slide of my talk. Usually we keep it at the end, but I wanted to make sure that I would take at least 1 minute to acknowledge all the people that have been supporting this project. And I would start first to say thank you to the CNET. You know, this is We are in difficult times now in research, having difficulty. It's very challenging to get funding support through the public research organization, and having this opportunity to get funded through dedicated organizations such as CNET is really, really helpful, and is really priceless. So today I'm going to be presenting the first part of the project that was actually supported by CNET. But I just want to let you know that we're also working on the molecular characterization of dipnic. And we're about to publish the first work I'm about to present, but we're going to be publishing also the second part of this work. And we're now working on the third part of this work with this research report that we got from CNET. So thank you very much again to all of you. And I want to thank the team. This has been a fruitful collective effort between pathologists, respiratologists, and radiologists, and students and residents. And without a single members of the people that you can see now, this work would not have been possible. So thanks to all of them, even if they're not here today. So what is dipnic? So dipnic stands, as pointed out by my thoracic surgeon colleague earlier, for diffuse idiopathic pulmonary neuroendocrine cells hyperplasia. And thanks for the compliment, by the way, to Dr. Simone. We do diagnose dipnic in our organization in pathology, and we actually have been doing that for quite a few years now, so thanks for the compliment. And what means idiopathic? Well, that's a name that we use in the scientific community when we don't know. So idiopathic stands for I don't know where it's coming from. Pulmonary neuroendocrine cells hyperplasia. And when we look at the definition of dipnic in the WHO classification of lung neoplasm, it stands for a generalized proliferation of multiple foci of pulmonary neuroendocrine cells that may be confined or to the mucosa of the airways or invade locally to form tumorlets or eventually a carcinoid tumor. And we pathologists are like artists. We like to look at things not in black and white like radiologists, but we like to look at things with color. So we're like radiologists with the high resolution tools, which is a microscope. And we add some color to it using different stains, including H&E stains. So what you see here is actually a piece of 2 centimeters of lung, where you see in the circle some dark areas which actually corresponds to foci of neuroendocrine cells hyperplasia and tumorlets. And you'll see that when you look at the radiology, that's basically the same thing that you see on radiology as well, but it's in black and white, of course. And you see that actually some of the bronchioli are spared by this process. Is there a laser? No, no laser? Okay, sorry. When we look at higher magnification, basically dipnic is a spectrum of pre-invasive and invasive neuroendocrine cell proliferation. So when you look at higher magnification on the left, you see that when it starts, it's confined to the airways, and the neuroendocrine cell will start to divide. And at some point, it will invade through the basal membrane and start to form small solid nodules of less than 5 millimeters. And then it will eventually progress to form carcinoid tumor, which by definition is a solid nodule of more than 5 millimeters. And this could be the histology corresponding image of what Dr. Simone presented when he showed you a nodule within a stem bronchi. And this is actually where you see some cartilage, and you see this mass of tumor cells that actually corresponds to a tumor that arose from the wall of a stem bronchi. And that's actually as pointed out by Dr. Simone, extremely typical of carcinoid tumor. And that's why these patients at some point will show symptoms, because basically the small airways and larger airways are being totally occluded by this proliferation. So at the clinical point of view, what is exactly the feature of dipnic? First of all, it's basically a disease of women, We don't know why, but when you look at different series of cases, it's mostly women. There's no association with smoking, and the clinical symptoms are kind of vague. Cough, chronic cough, that can progress to dyspnea, mild dyspnea, and sometimes can even progress, fortunately, quite rare, but to respiratory insufficiency. There's an airway obstruction also when you run a pulmonary function test in this patient. When you look at the radiology, you can see all the multiple small nodules within the lung. And when you get an expiratory phase, so patients are actually expire the air and then they get the scan, you can see that the air is being trapped within the lung parenchyma, which is another feature of bronchiolocentric lesion. This is, to my knowledge, the only attempt to come up with what are the diagnostic criteria to be able to recognize this condition. And this was proposed by Carr et al. In 2015, and these criteria were basically empirically chosen. So they look at different patients that were diagnosed with dyspnea and say, okay, these patients, a lot of them have specific radiology features, some of them have specific clinical presentation features. But as of now, there's no accepted and standardized and evidence-based diagnostic criteria for this condition. And we believe that this condition is likely underdiagnosed within the medical community. Some people are actually diagnosed as difficult to treat asthma. Some of them actually get a biopsy and they get a diagnosis of neuroendocrine tumor, but because of the multiple nodules, some of them are not treated because this is seen as a metastatic lesion. So there's a lot of confusion about the real definition of this condition. So the objective of this project was really to come up with standardized and evidence-based criteria to try to have a more homogeneous definition of the condition and to be able to know more about how it behaves and how can we study and how should we treat this patient. So the method of our study was, and I'm sorry, the few coming slides are a bit busy, but it's just to explain briefly why we did that and how we did that. So we went back in our archives and in pathology, and we selected a population of patients that had lung resection for carcinid tumor. So why carcinid tumors? Because there's a strong association with the presence of carcinid tumor and the development of dyspnea. So when you want to develop new criteria, you need to compare with a gold standard. But we don't have a gold standard because we don't have a clear definition of dyspnea. So the way we decided to go is we say we're going to create a consensus, an expert panel that will agree on definite cases of dyspnea, and this is going to be the gold standard. And then we collected a large number of clinical parameters ranging from clinical data, symptoms, pulmonary function test results, radiologic results, as well as pathology feature. And then we tested this feature in the dyspnea versus non-dyspnea group with univariated analysis, and then we came up with a model on multivariated analysis to try to come up with a clinical algorithm. And this is actually an important slide. Unfortunately, I cannot point you what I'm about to say, but basically, if you go up, we started from 105 cases, and then the residents, they collected all the data, and they looked which cases have at least one feature that could be relevant or in line with a diagnosis of dyspnea. And then if there was at least one factor, they would send it to us, the expert panel, and we would look at all the cases, all the different parameters in a blind fashion, independently, and we would say this is no dyspnea, this is unlikely dyspnea, this is likely dyspnea, and this is definite dyspnea. And when there was a disagreement among us, then we would discuss of all the different cases, And the ultimate goal at the end is to really have a pure population of dip neck that we're sure of the diagnosis, and there's a consensus among the three reviewers. And I'm not going to go into all these details, but when we then look at the different clinical features and we try to associate them with the dip neck and non-dip neck group, some of the parameters came back as significantly associated with dip neck. And again, just want to point out that this is univariate analysis. And among these factors, of course, the gender, so female was very strongly related to the development of dip neck, as we would expect, but also COPD, which means that probably this patient had a decreased pulmonary function at the time of the diagnosis, but also obstructive symptoms and gaseous retention on pulmonary function tests. We did the same thing for radiologic feature with different types of features that were reviewed by a radiologist. And then we found that some of the features, such as mosaicism, air trapping, a number of nodules were also associated with dip neck. And finally, we finished with pathology, looking at how many lesions we found in pathology, how many lesions per bronchioli, and we made a ratio with that, so it's stuff like that to account for the variability in the sampling method among the different cases. And then basically what it showed that the pathology exam on resection specimen was extremely good to predict the diagnosis of dip neck. And actually when you look at the sensitivity and the specificity, it was extremely high. We are talking about nearly 95% of specificity and sensitivity. And we also wanted to know how many lesions per bronchioli we need to see in pathology to make this diagnosis, to be able to suggest to the pathologist, you should take, when you have a diagnosis of carcinoma tumor, 2 or 3 or 4 extra block of the non-tumor lung parenchyma to be able to make a diagnosis accurately. And then we built our multivariate model where we used a limited number of parameters because of the low number of cases that we have in our cohort. But we use air trapping, multiple nodule, and other factors. And actually, these two factors came back very strongly associated with dip neck. And then we built a stepwise algorithm for the clinician. And we excluded the pathology from that because we thought this is not very useful. If you see a patient and you say, is this patient having a dip neck, and you need to send it for lung resection to make a diagnosis, that's not very good for the patient, right? So we wanted to exclude the pathology from the algorithm and just start from a patient with a diagnosis on a biopsy, on a cytology, on a small specimen of neuroendocrine proliferation, and then what do we see and what do we expect in clinic with a simple test that we can predict as accurately as possible if this patient has dip neck or not. So the conclusion of this project, we show that histology criteria predict very well the presence of dip neck. Appropriate sampling is extremely important of the non-tumor lung parenchyma. And I'm specifying non-tumor because these patients, just remind you, were operated for a carcinoma tumor. And then it's important also to distinguish from reactive neuroendocrine cell proliferation. So right now, we're working on a paper on the pathology point of view to recommend to the pathology, you should, when you have a diagnosis of neuroendocrine proliferation on a biopsy, you should do that, add extra blocks on the resection specimen. And if patient diagnosed with carcinoma tumor on a small specimen biopsy, then we should use the presence of multiple nodules on the chest CT along with air trapping as a very as a powerful predictor of dip neck. I mean, it's not perfect. The sensitivity is not perfect. It's 66%. But the specificity is quite high, around 90%. Now, the pros of this study is one of the largest cohort of dip neck patients published so far. Comprehensive evaluation of several parameters, multivariated analysis. I think those are strength of this study. First study to to use an expert, so an evidence-based approach to come up with diagnostic criteria. And I think before we can implement that in clinic, we will need to go and to validate this criteria on a prospective cohort. The experimental design is a retrospective, which has some inherent biases to it. And also, we miss some of the data. So when you go back in files and you look at the different clinical symptoms, we were missing a lot of information depending who wrote the clinical notes. So we had some limitation to this project. I wanted to suggest to use intelligence artificial, specifically when I heard Dr. Edzat's presentation this morning. So I'm sure he could help me on that part, right? So, and just to show you, this is the phase 2 of the project, which we have obtained very interesting findings. So I think this is really promising, and maybe at some point I'll need to come back here and show you what if we have a genetic component of deep neck. Thank you very much for your attention, and have a good afternoon.